Type B hypersensitivity reactions are bizarre, unexpected, undesirable effects that occur even when the dose is used in therapeutic doses by mechanisms unrelated to the main pharmacological effect of the drug. These reactions include drug allergy or hypersensitivity reactions, genetically determined abnormal response of a drug, and third, idiosyncratic reactions. Hypersensitivity reactions. Hypersensitivity reactions are of four types: type 1, type 2, type 3 and type 4 hypersensitivity reactions. Type 1 hypersensitivity reactions. Type 1 hypersensitivity reactions are seen in bronchial asthma, allergic rhinitis, allergic dermatitis, food allergy, allergic conjunctivitis and anaphylactic shock. Type 1 hypersensitivity reactions are IgE mediated. They occur in two phases, phase of sensitization and phase of reaction. In the phase of sensitization, the allergen enters into the body for the first time. The antigen presenting cells are present in the skin and lungs. The antigen is presented with the help of antigen presenting cell to the CD4 T cell. The CD4 T cell matures and there is class switching of B cell that produces antibodies. Normally, the B cell produces immunoglobulin G, M and A antibodies. Due to class switching of B cells, there is excess production of IgE antibodies. These IgE antibodies bind to the surface of the mast cells and the person is sensitized to the allergen. Next is the phase of reaction. Here the person who is sensitized to the allergen, when re-exposed to the same antigen, the IgE antibody recognizes it and there is activation and degranulation of mast cells leading to release of inflammatory mediators such as histamine, serotonin, tryptase, kinase, and this occurs within minutes. Therefore, this reaction is known as immediate reaction. Histamine causes vasodilatation, erythema, edema, itching, hypotension, and so on. In the late reaction, there is activation of phospholipase A2, which converts phospholipids to arachidonic acid, which in turn forms leukotrienes, prostaglandins, and interleukins. Leukotriene B4 is a chemoattractant and attracts neutrophils and eosinophils to the site of inflammation. Leukotriene C4, D4, E4 are powerful constrictors of smooth muscle and causes intense bronchospasm. Prostaglandin D2 causes vasodilatation of the blood vessels and increased permeability. Type 2 hypersensitivity reactions, also known as cytotoxic hypersensitivity reactions. Here the antigens are expressed on the cell surface of the target cell. The expressed antigen is recognized by the body's own antibodies as foreign and the target cell is destroyed by the following three mechanisms. The first one is the complement-mediated cell lysis. Second, antibody-dependent cell-mediated cytotoxicity. Third, opsonization. In complement-mediated destruction of the target cell, the circulating antibodies bind to the antigens on the surface of the target cell. The antigen-antibody complex causes activation of the complement system. Complement activation leads to activation of C3b, which is an opsonin, and enhances the rate of phagocytosis. C3a5a is a chemoattractant and attracts the neutrophils and macrophages to the site of inflammation. C5b678 is a membrane attack complex and forms pores in the membrane to destroy the target cell. So complement activation leads to destruction of the target cell. The second mechanism is antibody-dependent cell-mediated cytotoxicity. Here the antibody cross-links target cell with the cytotoxic cell. Now the cytotoxic cell releases hydrolytic enzymes on the surface of the target cell, killing the cell. The third mechanism is opsonization. Here the Fc region of the antibody binds to the Fc receptor of the phagocytic cells such as neutrophils, macrophages. The antibody-mediated cross-link between the antigen and phagocytic cell enhances the rate of phagocytosis, leading to killing of the target cell. Examples of type 2 hypersensitivity reactions are blood transfusion reactions, where RBC cell surface contains the antigens which is attacked by the antibodies produced by the immune response, causing lysis of red blood cells. The second example is that of medications like penicillin, thiazide, cephalosporin and methyl dopa, which bind to the surface of the target cell. This directs the immune system to recognize these modified antigens as foreign, with the breakdown of immune tolerance and the production of antibodies against the self-antigens. The third example is that of Goodpasture syndrome, where the antibodies are directed against the collagen in the glomerular and alveolar basement membrane. This leads to activation of complement system, which recruits leukocytes, resulting in inflammation. The fourth example is that of acute rheumatic fever, where the antibodies are directed against the streptococcal antigen, leading to damage of the heart tissue. Next example is that of Graves' disease, where the autoantibodies bind to the thyrotropic receptors on the thyroid follicular cells. Next example is that of myasthenia gravis, where the autoantibodies bind to the cholinergic receptors on the skeletal muscle end plate. Next is type 3 hypersensitivity reactions, which is mediated by immunoglobulin M and immunoglobulin G. These reactions occur in three phases, that is, the phase of immune complex formation, immune complex deposition, leading to inflammation and tissue injury. In the first step, there is excess release of antigen, which is followed by combination with antibodies to form antigen-antibody complexes. The antigen-antibody complex then gets deposited in various tissues such as skin, joints, vessels or glomeruli. The precipitation of the immune complexes in various tissues triggers the classical complement pathway. Complement activation leads to recruitment of inflammatory cells such as neutrophils and monocytes. This leads to release of lysosomal enzymes and free radicals at the site of immune complex deposition, causing tissue damage. Examples of type 3 hypersensitivity reactions are vasculitis and glomerulonephritis, classically seen in serum sickness, and Arthur's reaction. Type 4 hypersensitivity reactions are also known as cell-mediated hypersensitivity reactions. This is mediated by CD4 T cells and CD8 T cells. The antigen is presented to CD4 T cells, which is converted to T helper cells, releasing interferon gamma, which activates the macrophages, releasing cytokines. Cytokine release recruits inflammatory cells, causing inflammation, edema and tissue injury. The CD8 T cells directly kills the target cells by releasing perforins and granzymes. Perforins form pores in the membrane of the cell and cause cellular lysis, whereas granzymes increase the phagocytosis and causes cell death or apoptosis. Examples of type 4 hypersensitivity reactions are Stevens-Johnson syndrome, toxic epidermal necrolysis. These are life-threatening conditions that present with severe skin and mucosal necrosis with fluid losses and can present with hypovolemic shock. Next is genetically determined abnormal responses of a drug. Adverse drug reactions possess a strong genetic predisposition. An individual susceptible to an adverse drug reaction is often determined by their genetic makeup, since the genes play an important role in modulating the action and biotransformation of drugs. There can be pharmacogenetic variation in phase 1 drug metabolism. For example, the presence of atypical pseudocholinesterase enzyme, which mediates hydrolysis of succinylcholine, a depolarizing neuromuscular blocking agent. In healthy individuals, succinylcholine is hydrolyzed by pseudocholinesterase enzyme so that the action of succinylcholine is terminated in 5 minutes. However, there are some individuals who possess atypical pseudocholinesterase enzyme and they have low affinity for succinylcholine, This leads to slow metabolic degradation of succinylcholine, resulting in prolongation of effect of the drug. This intensifies the neuromuscular blocking action of succinylcholine, leading to respiratory failure and other side effects. The second example is that of codeine, which is metabolized by cytochrome P2D6, where codeine is converted to morphine, and morphine is a potent analgesic agent. There are 10% of people carrying gene variants that reduce CYP2D6 enzyme activity, and this reduces the ability to convert codeine to morphine and makes the drug ineffective. More concerning is 1 to 2% of people have CYP2D6 gene duplication, which means more faster and powerful conversion of codeine to morphine. For these individuals, a standard dose of codeine can result in toxicity and overdose and potentially death. The third example is that of phenytoin, which is metabolized by hydroxylation. In slow hydroxylators, phenytoin toxicity results. Pharmacogenetic variations can also occur in phase 2 drug metabolism. For example, isoniazid is metabolized by acetylation in presence of enzyme N-acetylase enzyme. In slow acetylators, isoniazid gets accumulated after repeated doses, leading to neurotoxicity and peripheral neuritis. In fast acetylators, isoniazid is metabolized faster, providing higher concentration of metabolic product, that is acetylhydrazine, causing hepatotoxicity. Next example, people with glucose 6-phosphate dehydrogenase deficiency are at increased risk for hemolytic anemia in states of oxidative stress. Idiosyncratic reactions are unpredictable and not explained by the pharmacologic properties of the drug. They result from mechanisms not clearly understood. Examples of idiosyncratic reactions are 1. A condition of malignant hyperpyrexia resulting from drugs like halothane, succinylcholine, and neuroleptic drugs. 2. Occurrence of aplastic anemia with a single dose or low doses of chloramphenicol. 3. Aspirin-induced late-onset asthma or chronic renal failure. These are some of the examples of idiosyncratic reactions. These are my references. Thanks for watching. Please like, subscribe and share.